Hi, my name is Heather, and this is going to be my final head to toe assessment for the semester. So, when you're about to go and do a head to toe on your patient, there's a few things you're going to gather beforehand. You're going to get your Dynamap, you're going to take in your stethoscope, and a lot of times people take in their computer to chart as they get their results so they don't forget before they move on to their next patient. So when you walk in, you're just gonna always use the head to toe approach. It's easiest. You go obviously from head to toe, and you don't forget an organ system, and it's just easier like that. So you're gonna also practice proper body mechanics. You're gonna do proper hand hygiene, patient safety, and privacy. And you're going to make sure that you explain to them what you're about to do. Sometimes, if a patient's confused, they can be frightened, they're in an unfamiliar environment, so just be gentle and explain to them what you're going to do. When you go in, after you've introduced yourself, and again, maintain patient privacy, safety, wash your hands, you're going to make sure you identify your patient. They should be wearing a name band, so you're just going to read the name band and you ask them to state their name, date of birth. You just need two identifiers. If you want to compare the MRN number on their band to the one in the computer, you can do that as well. So after you identify the patient, then you can just make sure it's a safe environment and you can proceed with your head to toe. You're going to start with your vital signs. You're going to check blood pressure. Proper blood pressure would be between 120 or would be around 120 at over 80. Temperature, you're going to look to be about 98.6. You can check orally or axillary, and the most accurate is going to be rectal. You also want to make sure your patient hasn't had anything to drink or anything really hot or cold before the temperature is taken to skew the results. Next, you're going to check respirations, normals between 12 to 20 respirations. You want to make sure they're not in any distress, not struggling to breathe or restless. That can indicate hypoxia. After that, you're going to check their pulse. Normal is 60 to 100. This is also something, if you're on a telemetry floor, I like to verify with the monitor tech that the rate on the Dynamap is the rate that they're seeing up there, also with their heart rhythm. And after that, you're going to check their pulse oximetry. Pulse oximetry should be between 95 and 100%, ideally closer to 100%. And you're also going to note if they're on any oxygen. A lot of people are put on 2 liters when they come into the hospital. And that's also will help you determine if they're in any distress. Like if their pulse ox is low in the 80s, maybe you want to go get a nasal cannula. If they're in distress, maybe you want to get a non-rebreather. Also, at this point, you'll also assess pain. It's known as the sixth vital sign, and pain is always what the patient says it is. So if they're able to rate it, they're alert and oriented, you're going to ask them to rate it on a scale of 0 to 10. I always elaborate and say 0 being no pain, 10 being the worst, just to clarify. And then you're going to chart that as well. If they're unable to speak, you're just going to observe them. Are they in distress? Look on their face, anything like that. So once you've done that, you're going to start with your head to toe approach. So I'm going to start with my patient's head. You're going to take a look at the hair. You're going to take a look at the cranium, make sure everything is equal in shape and nothing is asymmetrical. You're also going to take a look at their temporal pulse. From there, you're going to move on to the ears. The ears, you just want to make sure they're symmetrical, that the tympanic membrane is intact. You also want to make sure they can actually hear you. You could do the whisper test. I've done this in the past where you just stand out of sight and you whisper something, and then you see if they can just repeat it back to you. Sometimes there can be an overgrowth of hair in an elderly gentleman's ear. You just want to make sure the ear is clear, and you can also assess to see if they have a hearing aid. Many patients, if down here in South Florida, we have an elderly population. A lot of them do use hearing aids. Some of them don't want to, and therefore they're hard of hearing. Once you're done with the ears, I forgot to say before that, you're going to just do a general survey. Look at their skin, look at their color, look at the turgor. Turgor can indicate dehydration. Color can indicate that there's something going on. Like if there's yellowing of the skin, that could mean that they have jaundice. If they're dry, you just want to look for any abnormal looking things on the skin, any discoloration, anything like that. So then you move on to your ears, your eyes, and everything on the head. So next with the eyes, you're going to make sure you're going to look at the conjunctiva and see what color it is, the sclera. If there's any yellowing, that could also be an indicator of jaundice. You want to do your perla, make sure your pupils are equal around and reactive to light and accommodation. So you'll take your pen light and you're just going to shine it in their eye. Obviously let them know beforehand so they're not taken aback by that. And you're going to make sure that everything is responding as it should be. You can also ask about a history of like glaucoma or anything like that, because some patients have had pupils that actually just stay large, and that's normal for them. You're going to want to just make sure that their eyes are working as they should be, and that they're accommodating. There's no blurriness of vision. You can assess if they're wearing glasses, ask how long they've been wearing them, also if they can answer these questions. So then you're going to go on to the nose. You're going to make sure that it's symmetrical. There's no drainage. You're going to make sure that the patient isn't having any difficulty breathing. And then you can move on from there. You can move on to the mouth. You're just going to ask them to open up. You're going to take a look at the mucous membranes. You're going to take a look at their gums, their teeth. You want to make sure their lips and everything's symmetrical. Maybe if they've had a stroke, it'll be drooping on one side. From there, you can take your pen light and actually look at their uvula and their tonsils and make sure nothing's swollen, red, irritated, anything abnormal, really. You can see if they have dentures, if they have any gum disease, anything like that, because some of that can contribute to other health implications. From there, you can move down to the neck. You're going to want to make sure that the neck, you see symmetry. They're not holding their head to one side. You can check their range of motion, so you move it around a little bit. You're going to make sure that the patient doesn't have any issues turning left or right. That's mobility. You can also check their veins and arteries. So you have your carotid arteries on the side. You never want to palpate both at the same time because that can cause the patient to pass out. You're going to want to take a look at the trachea, make sure everything's midline and symmetrical, which back to the mouth, you want to do that too. You want to make sure the tongue is midline and symmetrical and they're not having any issues. Back on the neck, you want to look at the supraclavicular veins, make sure everything is as it should be. Any jugular veins, you can look at jugular venous distension and note anything that's abnormal. From there, you're going to go to the neurologic assessment. You want to make sure your patient is alert and oriented, or see how alert and oriented they are. There's alert and oriented times 4, 3, 2, 1. You want to make sure just to ask them, tell me your name, tell me the date and time, do you know where you are? Ask them simple questions, do you know who the president is? Do you know why you're here? Just simple things like that, and you can assess if they're oriented, disoriented, if their mental status is okay. Here you'll also assess the patient's cranial nerves. If anything abnormal is going on, and just check their level of consciousness. So once we're done in this area, then we can start to move downward towards the body, or the main part of the body. You can assess your upper extremities. I always ask my patient to see if they can lift their arms first, and that would be active range of motion in their upper extremities. You want to check if they could do any movements. You can touch their hands, make sure they're feeling things as they should be. They haven't lost sensation or anything, and that their movement is appropriate for them. You want to check capillary refill down in their hands and see how long it takes. Like, is it brisk? Is it sluggish? If it stays pale or too long. You can also check their fingertips and make sure there's no acrocyanosis going on. If they were having breathing problems, it would be blue. It's turning off. Then you're going to check range of motion and muscle strength. Range of motion we already did. Muscle strength, you want to see if you give them resistance, can they push back? And if you have to do the motion for them, that would be passive range of motion. So once you're done with that, you can really move on to the anterior thorax of your patient. You're going to start with the shape of the chest. Make sure there's not like a barrel chest going on or anything abnormal. You just want to look at this patient's skin. Let them know what you're doing, because it could be a little, you're getting kind of invasive here, especially if it's a woman. You're going to want to observe the patient's breathing, if they're restless, if they're labored, if they're lower than normal, and that goes back to the pulse ox and respiration count. This is when you'll take your stethoscope, and with your stethoscope, you'll listen to the patient's breath sounds. You're going to want to listen on the left and the right. You're going to go in a proper motion, left, right. You go downward and outward, listening for breath sounds. A lot of the elderly population has diminished breath sounds. If someone, for example, has fluid in the lungs, it could also sound like crackles, and it can be indicative of congestive heart failure. You can also have someone with wheezing, and that could be a patient who's got some pneumonia going on, or COPD. There's a lot of respiratory issues that could be going on, and you just want to make sure that everything's okay. You also I ask my patients to sit up at this point, and I take a listen to their back as well. So I listen to the front as well as the back, and I usually ask them if they're having any difficulty breathing. And then also, you don't want to make note if they're wearing a nasal cannula or anything like that, or if they need something because they are struggling. From there, I usually continue on to listen to the heart, which is on the left side of the chest. You're going to want to listen to the precordium. You're going to want to listen to, see if they have any S1, S2 sounds, what their heart rate is. If it's irregular, atrial fibrillation is an irregular heart rate, so you're going to hear something different than your normal heart rate. And you're going to also want to just make sure their heart rate isn't too low or too high. This is normally the part of the assessment where I'll also ask, do you have a pacemaker? Do you have an AICD? You'll notice if a patient has like a life vest, anything like that, anything going on with their heart. And then later on, if you're on a tele-Ford, you just always want to make sure you look at your strips and see what their heart rhythm is. If they're in atrial fibrillation, that's a common irregular heart rate. If they have a pacemaker, A pace, V pace, AV pace. And then if they're in sinus rhythm, is it sinus brady, sinus rhythm, sinus tachycardia. Again, normal is 60 to 100. Tachycardia is 100 or above. And then your bradycardia is going to be 59 or lower. So from here, we're going to move on to the breaths. Again, for women, it can be a little uncomfortable, so you just want to make sure you tell them what you're doing. You're going to want to assess the nipple area on the patient, make sure they're equal. You're going to want to check their axillary nodes. I usually also ask if there's been any history of breast cancer, which you should know at the very beginning, because if they've gone in on that side and done anything with the nodes, you shouldn't be using that limb for anything. So if the patient had something done on the left side, you're not going to want to use the left side for blood pressure. Generally don't want to start an IV on that side, anything like that. So you just want to make sure you're doing the right thing by your patient. So after the breasts, you're going to move down into the abdominal area. So now I'll just lift this up because it's a little more accessible. I couldn't get to the chest. So for the abdomen, you're going to want to make sure you're looking at a symmetrical abdomen. You're going to want to look at the skin color. You're going to want to check for bowel sounds in all 4 quadrants. You're going to go, I usually start in the left, go down to left upper quadrant. You go down to the left lower quadrant, then to the right lower quadrant and right upper quadrant. You're going to want to note if it's hypoactive, normoactive, or hyperactive. Just make sure you have sounds. And you're going to listen to them before you actually touch the patient's abdomen, because if you touch the patient's abdomen, you're going to disturb the natural processes, and you might be listening to something that you created rather than what's going on with the patient. So after you listen, you're going to want to assess the patient for any tenderness, any rebound tenderness. If they're having anything going on when you push with like a gallbladder or anything, they're going to have pain. So you're going to want to make note of that. You're going to assess the livers in the abdomen, and anything that goes on with the liver, like if a patient is jaundicing or something like that, that's going to be a liver problem. You've got your spleen here as well, which is the bloodiest organ. You're just going to basically assess for pulses. You've got your femoral pulses. If your patient has a femoral line, you'll notice that in your assessment too, which is an invasive line. Sometimes if they can't start an IV, they'll do something in the femorals. Maybe if a patient has had a cardiac catheterization, they go in through there, and you just want to assess that the artery is intact, the patient's not bleeding. If the patient has a Band-Aid or a dressing, you're just going to make note of anything abnormal or unusual. From here, also, the patient's bladder is here. So if the patient has any distension, that could be an issue with urination. So what you're going to do is palpate. If it's distended, then you're going to get a bladder scanner and see how much they're holding. If you need an order from a doctor to maybe straight cath the patient to help them, I've had that. If you're going to want to put a catheter in, you'll also note if the patient has a catheter. These are all things that need to be charted, and they're very important things. So after you note the bladder, then you're going to go check their, ask them, do you have difficulty urinating? Do you have difficulty going to having a bowel movement? When was your last bowel movement? The patient may be on a gentle laxative or something just to help them. So you'll ask questions like that. After you do the abdominal assessment, you'll move on to your lower extremities. You're going to also, like the upper extremities, check range of motion. If it's active range of motion when the patient does it by themselves, if it's passive and you have to help them, you want to test their muscle strength, see if they can meet resistance. You want to check their reflexes. You can tap their knee and see how that works. You're going to assess for edema. A lot of congestive heart failure patients have edema. You're going to want to see if it's pitting, non-pitting, 1 plus 2 plus 3 plus 4 plus, all of those. You're going to want to check your patient's toenails and check for, see if when you push down on them, if it's brisk or sluggish return. You're going to want to check, that's the capillary refill, sorry. The edema, I said, and edema can come from the congestive heart failure if the patient's suffering for that. So they might be on a diuretic, IV Lasix, or even PO Lasix. It'll help take the fluid off. And if you have a patient more than, 1 day in a row, you'll really be able to assess the difference and see if their fluid is going down. After that, I usually have my patient turn over. Or if I need assistance looking at their backside because the patient's unable to turn over themselves, I'll do so. I usually lay them on their side. I don't lay them on their backs, but for the purpose of this video, I'm just going to lay them like this. But I would normally just have them on their side. I would assess for any discoloration. If they're immobile, you want to check for any pressure ulcers, discoloration. They might have a foam or Mepilex on their bottom just to protect them, really. You're going to want to check skin symmetry, their spine, make sure if it's straight, maybe they have scoliosis. You're going to want to, maybe they have osteoporosis and they have a really big curvature or hump or anything. We already did the breath sounds. I like to do that earlier with my respiratory assessment all in one. But that's pretty much it for the backside. It's really just color, skin, discoloration, any open wounds, look at their spine, their buttocks. You can also ask them if they've had any bowel movements, any redness if they're going a lot. You might want to put cream on them, help them be a little more comfortable. So then you're going to go back to the front and You can assess the patient's genitalia. If it's a male, you're going to look at the penis, make sure the foreskin or anything's intact, there's no discoloration, nothing, crusty. You can assess a patient's level of cleanliness by seeing how well they take care of themselves. If there's a lot of built up things on there, sorry, my computer turned off again. If there's a lot of built up like crustiness, it's dirty, you're going to pull back on the foreskin. Just make sure everything's intact in the perineal area. Make note if there's any tender areas. You're going to see maybe if it's a male patient, maybe they have a hernia or something. Sometimes men they have stuff all their lives, and that's just what it looks like. You just want to find out what's normal for the patient, if there's anything acute going on that you need to take care of, and same with a female. You want to look at the labia, make sure there's no rashes, the patient has a yeast infection. If any of patients have Foley catheters or anything like that, you just want to make sure that the Foley is clean, because this is a huge risk for infection, and a lot of hospitals are battling this. It needs to be clean. Where I work, every patient needs to be bathed in a chlorhexidine bath daily. So you just want to make sure of that. And if a patient's incontinent of stool, then it could be on the Foley. So you really just want to make sure everything's clean, draining properly, anything like that. And from there, you're really just going to wrap things up. You're just going to summarize whatever you just assess on your patient. You're going to put it in your charting. A lot of hospitals are making a transition by charting by exception. So you don't chart on what's normal, you chart on what is abnormal. So it actually streamlines the process of charting. So you're going to chart all the abnormal findings. So if they had diminished breath sounds, you chart that. If it's clear, you don't chart it. If they're in atrial fibrillation, that's irregular, so you chart that. If they have a pacemaker, that's not that it's not normal, but it's not what's necessarily expected, so you chart that. If they're in sinus rhythm, sinus bradyia, sinus tachycardia, even though those are higher in lower rates, they're still sinus, so it's acceptable. You do not have to chart on that. So then after that, you're just going to ask the patient if they have any questions about anything. Normally they do. I usually just explain as best I can. Most people like to ask when the doctor is coming, and I don't know that. But I'll explain anything about their diagnoses that I can, anything about upcoming tests that I can, anything about if they have a question about their body or what's going on, like why do I have edema, I'll explain about congestive heart failure or something and what we're going to do to treat it. And that's pretty much it. So make sure they're comfortable. Give them the call bell, make sure their TV, comfort items, phone, anything is close to them, and really just that they can get in touch with you, and make them comfortable, answer their questions. So then after that, I usually take my gloves off, and I will go wash my hands, and then I will finish any charting I have to do on my patient, and just make sure the patient's comfortable, lights on, bed is locked, and that they're safe. And that's going to be it for my head to toe.